A brief overview. Cystic hygroma, also known as lymphangioma, is a congenital malformation of the lymphatic system characterized by fluid-filled sacs that result from abnormal lymphatic vessel development. These sacs are often multiloculated and contain lymphatic fluid, typically arising due to an obstruction or failure of the lymphatic system to communicate with the venous system during fetal development. Clinical presentation. Cystic hygroma commonly manifests in infancy or early childhood, though it can occasionally be diagnosed prenatally or later in life. These lesions are most frequently found in the neck, posterior triangle, or axillary region, but may also occur in other locations, such as the mediastinum, retroperitoneum, or groin. The condition presents as a soft, painless, and compressible mass that may increase in size over time or during infections. In severe cases, particularly when the hygroma is large, it can compress nearby structures, causing complications like airway obstruction, dysphagia, or vascular compromise. Etiology and risk factors. Cystic hygroma results from a failure in the normal development of the lymphatic system. Risk factors include chromosomal abnormalities. Conditions like Turner syndrome, 45X, and trisomies, e.g., trisomy 13, 18, or 21, are commonly associated. Environmental factors. Exposure to infections or toxins during pregnancy may increase the risk. Diagnosis. The diagnosis of cystic hygroma is often made using imaging studies. Prenatal ultrasound detects cystic hygroma as a multiloculated cystic mass, sometimes accompanied by fetal hydrops or other anomalies. Postnatal imaging, magnetic resonance imaging, MRI, or computed tomography, CT, helps delineate the extent of the lesion and its relationship to adjacent structures. Treatment. The management of cystic hygroma depends on its size, location, and associated symptoms. 1. Observation. Small, asymptomatic lesions may only require monitoring. 2. Surgical excision. Complete removal is the treatment of choice for symptomatic or enlarging lesions. However, recurrence is possible if the resection is incomplete. 3. Sclerotherapy. Injection of sclerosants, e.g., doxycycline or bleomycin, can reduce the size of the lesion, especially for lesions in anatomically challenging areas. Prognosis. The prognosis depends on the size, location, and associated anomalies. Isolated cystic hygromas have a better outcome, while those linked to chromosomal abnormalities or other systemic conditions may carry a poorer prognosis. Cystic hygroma highlights the importance of early diagnosis and multidisciplinary management to prevent complications and improve outcomes for affected individuals.